due to a lordotic cervical spine and a kyphotic thoracic spine, and there is high possibility for construct failure as well. So an ideal fixation at this level should have an excellent safety profile as well as a biomechanically stable construct. So we have few treatment options available that are quite popular: lateral mass fixation, pedicle screw fixation, and the one I'm going to talk about, translaminar screw fixation. So regarding lateral mass fixation, it is relatively safe and easier to construct. But what could be the problems? It's the decreasing size of the lateral mass in the lower cervical spine, and which may have a decreased pull-out strength and may lead to screw loosening and a construct failure. So regarding pedicle screw fixation, everybody knows that's a biomechanically more stable construct, but it is technically demanding and it has a potential risk of injury to the neurovascular structures, and it is going to variations in the pedicle trajectory in anatomical wise, and the conventional fluoroscopy is difficult at the cervicothoracic junction due to the presence of the shoulder girdle. So these problems made it quite difficult for these procedures in our clinical setup. So we thought of a potential alternative technique or a bailout technique in such difficult scenarios. So translaminar screws, they are expected to meet the high biomechanical demands and avoid such complications. So it achieves stabilization of the vertebral spine by insertion of screws at the base of the spinous process and through the opposite lamina. So these are the directions. So what are the advantages? They are biomechanically comparable to pedicle screw fixation, does not require any specialized equipment, lesser operative time, less cost and fewer complication rates, which we have to prove although. And there are always certain disadvantages as well. That cannot be used in the upper cervical spine regions where the laminar thickness is inadequate, and there could be a breach of either the dorsal cortex or the spinal canal. So our aim was to study the applicability and the feasibility of this technique, especially in certain compromised situations like inadequate image guidance. So we did a complete neurological assessment and a lateral cervical X-ray with full arm, both arms in traction to visualize the junction. An MRI was CT was done to rule out any fractures of the lamina or the spinous process where the technique would be difficult or not possible at all. An MRI to see any disc retropercussion, which may need a global procedure. So we included cases with C7 T1 subluxation mainly, and certain cases of C5 C6 subluxations also. We excluded cases with laminar fractures and spinous process fractures and with disc retropercussion. So we could always go with the laminar screws or a polyaxial screws, but we decided to study using cortical screws, 3.5 mm cortical screws and reconstruction plates. So we proceeded with a routine posterior approach, exposing the cervicodorsal spine, and the entry points for the screws were staggered at the base of the spinous process on the opposite side, so that the two screws did not collide or violate the cortex. And we had a handle to drill the contralateral lamina to a preoperatively estimated depth, but along the desired trajectory. The screw trajectory of one side is different from the other, and along the thickest part of the lamina. The desired trajectory is along the junction between the middle and the inferior third of the lamina. So the length of the hole was then palpated with the probe to confirm there was no breach of the cortex, and 3.5 screws were held with recon plates, and they were usually we tried to insert manually without image guidance. So but as we go higher, we used routine, we want to put the screws in above C7, we used routine lateral mass screws, and below C7 and T1 we used laminar screws. So all patients were immobilized with cervical brace, and they were evaluated 6 weeks, 3 and 6 months with both X-rays and CT scans. So we had 11 cases in our study. Most of them were males, and fall from height predominated the cause of injury. And the neurological status, incomplete deficit was the majority of cases. And the stability was noted in all cases with the CT scan and dynamic X-rays. And there was no screw pull-out or screw fractures in any case. There was one case of violation of the screw in the spinal canal and one case of dorsal breach. So 6 out of 9 cases with incomplete neurological deficit showed marked improvement to near normal status. 3 had no or minimal neurological improvement, and 2 cases of complete deficit were neurologically static. So these are some of the cases. Case of C7T1 subluxation with incomplete deficit. We proceeded with translaminar screw fixation. At 6 months follow-up, there was no any complication regarding the screw pull-out or failure, and this was a similar case. This was one case C6, C7 subluxation, where we proceeded with lateral mass fixation at C6 and translaminar screw fixation at C7 level. This was a case where we had a laminar fracture at C5. So, and there was a lateral mass fracture also at C6. So, we proceeded with lateral mass fixation at C4 and laminar screws at C6. And this was a case to demonstrate a possible problem. We had a breach of the spinal canal at D1, but there was no neurological deterioration post-operatively, and we had planned for implant removal at after we could see a fusion or a neurological improvement. So to discuss the possibility of a strong construct of this system is due to the ability of the screws to control motion along multiple axes, and the trajectory of the screws is not along the axis of motion of the cervical spine, which could explain the increased pull-out string. And there is a minimal risk of injury to neurovascular structures because it remains in the posterior elements, and the trajectory is fairly reproducible because whenever we plan for a dorsal trajectory. So to conclude, posterior subluxation cervicothoracic junction, translaminar screw fixation gives good results. As a newer technique, it's mainly an alternative to routine pedicle screw fixation with biomechanical compatibility, and it is easy to adopt with a large margin of safety. It provides stronger fixation with accurate screw placement without image guidance. So therefore, we believe C71 translaminar screw is a viable option for injuries around cervicothoracic junction, even though further clinical analysis is necessary.
No,
Thank you.
Any questions on this? Okay, I have a question for you.
Yes.
You said that you use it at below C7.
Yes.
So basically, this is for cervicothoracic junction.
Yes, sir.
So it's not translaminar screw fixation in lower cervical spine. It should be called cervicothoracic junction. Yes,
sir.
correct?
Yes, sir. But we had certain cases where we had laminar fractures, and we had to extend it even for C5, C6 subluxation. That was one case. So we had.
So, but still, most of your cases were
Yes,
for
sir. Yes.
Second thing is you have done a biomechanical study. You said a screw pull out.
Yes, sir. Only on patients. We had follow up, not on any
Not
cadaveric.
really.
No, sir.
So you are not sure whether just a one level above and a one level below translaminar screw in a cervicothoracic junction is sound.
Yes, sir.
That's a worry.
Yes, sir.
So anyway, anybody else has a question? Yes, sir. Please tell your name and then ask the question.
I'm Dr. Sandeep Sonani from Mumbai. Most of these cases, you haven't done any decompression.
Yes, sir. No.
And from what the cases that I could see was that there was no anterior surgery as well.
Yes, sir. Only those cases which didn't have a discal element we
And
proceed.
from whatever examples that we saw were the cases of fracture dislocations.
Yes, sir.
And the clinical results say that most of these patients recovered. So, I mean, without decompressing, you said that most of the patients recovered by indirect decompression at the cervicothoracic junction.
Yes, only 6 cases. They were already of incomplete neurology. They were not of complete neurological deficit, but they only these cases. These cases we did not plan the whether to decompress or not. We didn't plan based on this study. Only cases which we plan to proceed without decompression. That is by indirect decompression we proceeded with screw fixation.
Okay, but what he says is quite relevant. It's very difficult not to decompress. It's very difficult to indirectly reduce, especially with these little screws you have. And it would be a worry to, and especially these patients who have fracture dislocations would have a lot of laminar fractures.
Yes, sir.
And so it may not be obvious. So there are problems, but definitely it's a newer technique. And I have used these techniques sometimes. Next speaker is good. Next speaker is feasibility of a single anterior release and anterior instrumentation in irreducible atlantoaxial dislocation. Sandeep Sonom. Is he here? Yeah. Sir, namaskar.
This is a 5 minutes presentation. Right? Yeah. Okay.
Yes, sir, please. Thank you. I think we started a little late.
Good morning. The treatment of irreducible or so-called fixed atlantoaxial dislocation is quite controversial even right now. Various options which have been propagated are a prolonged period of traction followed by posterior surgery or anterior surgery and posterior fixation. But right now the uniform consensus where we stand is there is definitely a role of anterior transoral release followed by posterior fixation. We went a step further and analyzed our results in a few patients who underwent anterior release and anterior fixations in fixed atlantoaxial dislocations. The surgeries were done at a university hospital in Mumbai. We did not receive any funding or financial support from anyone. Prior to embarking on the surgical journey, we had a cadaveric dissection in around 16 patients in which we analyzed the various parameters of the C1, C2 joint complex, which definitely had a say in the final decision making. 8 patients were operated on, age range vary from 9 years to 55 years, 3 males, 5 females, and most of these patients have neurological involvement. Pre-operative investigations, X-rays were done to document the irreducible nature of the deformity. CT angios were done to assess the status of the vertebral artery, and MRI was done to document the cord compression and assess the cervicomedullary angle. The patients were admitted, treated with traction, which varied from 6 days to 8 weeks, and they were monitored clinico-radiological during this period. Once this, the decision of surgery was taken, the proper counseling was done and consent was taken, including a consent for an intraoperative wake-up test. Through an anterior approach, a retropharyngeal approach, I went in,
You have 3 minutes left, so you want a pointer. He wants a pointer. Who
no,
are the
actually I want a video.
organizers?
The video is not playing over yet.
Okay.
The video is to play in the preview room.
Anyway, don't worry. Go ahead.
So through an anterior approach, I took a long retropharyngeal incision, cervical incision. So in retropharyngeal approach, did a release on the concave side, release the longest scoli, opened the joints. That is how the joints looks. That's the joint on the right side. I excised the anterior joint capsule, incised the posterior joint capsule, kept the lateral capsule intact to protect the vertebral artery. After releasing the joints, I distracted the joints by putting in a 8 mm puka chisel one at a time, gradually distracting, keeping a watch on the neurology. And once the joints were distracted and realigned in extension, then the reduction was achieved. Once the reduction was achieved, I took out tricortical grafts from the iliac crest, put into the facet joints, decreased the traction to jam the grafts in place, and then instrumented it in the form of transarticular screws or anterior C1, C2 plating. The total duration of surgery was 3.5 hours. Blood loss was around 250 cc. Most of these patients required an ICU stay for around 2 days. Post-operatively, they were in bed for 4 to 6 weeks and mobilized with a brace which stayed till 6 months. CT scans were done in most of these patients at 6 months follow-up. There was significant reduction of basilar invagination. There was a moderate correction of the posterior tilt of the odontoid. However, the cervicomedullary angle correction was from 105 degrees to 128 degrees. One screw had a medial cortical breach at C1 which was asymptomatic, and follow-up CT scans done at 6 months showed good radiological union in most of these patients. Clinically, 6 patients recovered their neurological status by 2 functional grades. Earlier recovery was seen in young patients. However, we lost 2 patients in which one was already a case of already grade 3 myelopathy, in which the wake-up test was negative, and this was a syndromic patient, a child which we lost because of this particular procedure. In our series, the failure percentage was 25%. Case examples: a 50 years old female patient, case of atlantoaxial dislocation. You can see that the cervicomedullary angle is quite decreased, 110 degrees. I went in, did an anterior release, distracted the joints, realigned in extension, tricortical grafting, and anterior transarticular screw fixation. And that's a CT scan at the end of 6 months, going good radiological union in the C1, C2 facet joints. Another case of 40 years old female, a case of basilar invagination due to rheumatoid etiology. Again, did the same procedure, realigned the joints in hyperextension, put in a graft, and did a C1, C2 plating. In this case, the C2 lateral mass on one side was dysplastic, so I had the option of plating into the C2 body. That's the CT scan at the end of 6 months, which shows that there's a good radiological union at the C1, C2 facet joints. So to conclude, I feel that this particular approach definitely has got an advantage over a trans-over release. It can be used in cases in which the posterior transarticular screw is contraindicated, like narrow C2 pars or vertebral artery foramen abnormalities. Thoracic hyperkyphosis, in which probably we might not get a trajectory for a posterior transarticular screw. However, it cannot be done in cases where there is a retroverted odontoid, or when the patient is a syndromic AAD, in which there is a fusion of C1 arch posteriorly, and this which requires a foramen magnum widening. Thank you for your kind attention.
Thank you. Any questions? Any questions for the audience? From the audience? No? Nobody wants to ask a question? Okay, I have a question for you. You have basically reduced it. You have released the capsule anteriorly and released it, and you've jacked it up. So you're not removing the odontoid process.
I'm not removing the odontoid per se.
So how many, they have significant basilar invagination. This is Goyle's technique which you,
So
modific-
Goyle's technique is slightly, it's from the posterior side,
Huh.
but it doesn't release the odontoid. It's it's basically the jacking up of the facet joints.
opposite,
Yeah,
yeah.
So
So-
in this case, we actually don't have to release the remove the odontoid, because we can go in the space between the C1 and the odontoid and remove the tissue over there. In fact, we can do an undercutting of the C1 arch without actually excising the C1 arch. So you are preventing the stability of the C1 ring. You are maintaining the stability of the C1 ring, and that allows the reduction of the odontoid into the space which is created between the C1 arch and the anterior aspect of the odontoid, because most of the tissue is over there, and that tissue can be removed without removing the C1 arch or the odontoid.
Yeah, my question was slightly different. Have you checked up in all these CT scans? You said you've done CT scans in all, you had 11 patients.
We have 8
Eight
patients, we have done
patients,
CTs in 6 patients.
6 patients. In all these patients, 6 patients whom you did a CT, did you find that the canal anteroposterior diameter was reconstituted in all of them?
The
Or what-
the cervicomedullary angle depends on 2 things. One is the vertical offset, second is the retroverted odontoid. We could get good vertical reduction of the vertical offset. Probably the angle of the odontoid was not too much corrected, but then with the newer, this was a study which was done around 2 years back. Now we are doing the same thing, in which we have modified the implants, so that in that case, with those implants, we are getting a good correction of the odontoid.
Because that's a worry, isn't it? You may get a superior inferior.
Clinically, what matters is the increase in the cervicomedullary angle, either by a vertical increase in the offset or by correction of the posterior tilt of the odontoid. Either ways, if there is a basilar invagination, even if you do a minimal correction of the posterior inclination of the odontoid, by increasing the vertical offset, you are increasing the cervicomedullary angle, which is what we want ultimately.
Maybe, yeah. Anybody else? Good, thank you.
Thank you.
Can we call the next speaker is safety and efficacy of cervical pedicle screws, a pilot study in Indian patients. Piyush Kumar, is he here? Good. Your time starts now and you have 5 minutes.
Good morning all. My topic is the safety and the efficacy of cervical pedicle screws in Indian population, a pilot study. I am Piyush Nashikar from KEM Mumbai. As we all know, this cervical pedicular system has become a popular way of posterior cervical fixation because it is biomechanically superior but carries a potential risk due to proximity of vertebral artery, cord and the nerve root. However, most of these studies have been conducted in western part of the world and Japan. Our aim was to assess safety, accuracy and the complications of the cervical pedicle screws in Indian population. The most important part of this study was the CT scan. So we assessed the preoperative dimensions, abnormalities of the pedicle, then postoperative dimensions of the screws and the violation of wall. We also assessed the injury to vertebral artery, root and the cord. We used keyhole technique. In this, we made an entry hole with the burr on posterolateral part of the lateral mass. We negotiated the pedicle through with the help of probe and checked it under the C-arm. Then we tapped the path and screw was inserted and checked under the C-arm. We operated 12 patients with an average age of 48 years. Indications were atlantoaxial dislocation, trauma, tuberculosis, degenerative disc disease and OPLL. We inserted 52 screws. 6 screws that were inserted in situ were excluded. So we analyzed 46 subaxial screws. We used 3.5 mm polyaxial screws with the mean length of 20 mm. The medial angulation was for pedicle was 14 to 56 degrees with an average of 36 degrees. And for screw it was 10 to 45 degrees with an average of 28 degrees. Safe zone for the pedicle was 20 degrees in mediolateral plane, and for screw the medial angulation was 10 to 15 degrees less than the trajectory of the pedicle. The angle of the screw with the superior end plate was minus 10 to 15 degrees with an average of minus 4. Ideally this screw should be parallel to the superior end plate so that it will have an hold at the pedicle entry point and at the junction of pedicle to vertebral body. When the wall of the pedicle was not visualized on axial scan and more than 2 mm of medulla was detected on the other side of the screw, we call it a pedicle breach. 8 out of 46 screws, that is 17% of the pedicles were breached, and rest, that is 83% of the screws were completely inside the pedicle. When the whole screw was outside the confines of the wall, we call it a frank penetration, which was 8.7%. One of the 6 screws that breached laterally actually caused the vertebral artery injury, but patient was asymptomatic. inferior perforation rate was 6.5 and medial perforation rate was 2.4, though none of the screw impinged on the cord or the root, and all patients were asymptomatic. 11 out of 46 screws pedicles were sclerotic. 18% of the sclerotic pedicles actually had a breach compared to 17% of the non-sclerotic pedicle. So we got a guidelines like 26% of pedicles were sclerotic with slightly more perforation rate compared to non-sclerotic. The medial angle of the pedicle was 36 degrees and that of screw was 28 degrees with a safe zone of 20 degrees. The screw should be parallel to superior end plate. The mean length of the screw was 20 mm with a diameter of 3.5. 83% of the screws were completely inside with a satisfactory placement rate in 91%. The frank penetration was found in 8.7%. Then none of the patient developed neurodeficit or radicular pain. Only one patient had vascular artery injury, but it was asymptomatic. So clinical complication rate was 0%. This OSMA is a FDA approved globally accepted body which has filed a reclassification petition for lateral mass and pedicle system in August 2012. They have compiled the study of 35 studies on the cervical pedicle system, and most of the studies shows the satisfactory placement rate between 85 to 100% with a clinical complication rate between 0 to 6%. In our study, we get the satisfactory placement rate of 91% and clinical complication rate of 0%. So to conclude, result of these studies were comparable with the studies conducted outside the India. Cervical pedicle screw fixation is reliable and risky, and it should be preferred treatment for posterior cervical fixation in selected Indian patients. CT scan is essential prerequisite for cervical pedicle screw fixation, and more studies will certainly help in defining the various parameters of cervical pedicle in Indian patients. Thank you.
Good. Any questions from the audience? Yes.
You have shown in your cases the penetration of the pedicle screw in a few of the cases. Was related to the condition of the bone, like if the bone is severe osteoporotic, you find more penetration of the screws, or what precautions you took when the bones are severely osteoporotic in some of the cases of yours?
Actually, my patients were between the age of 14 years to 56 years. So, and most of them had a OPLL or the trauma, and some of them had AAD. So actually we didn't find any osteoporotic bones in which we actually put the cervical pedicle screw. All the bones were fine. So we don't have any experience with the perforation rate in osteoporotic patients. But it is said that in osteoporotic patients also, the cervical pedicle is better than lateral mass screw because of it is greater pull-out strength and has a longer length of purchase.
Okay, I have one question. What was your indication in OPLL? Because most of the OPLLs that I do, I just do a laminoplasty or a laminectomy because they are fairly stiff, they are not unstable, and why would you go into putting a cervical pedicle screw in a patient with OPLL?
In OPLL, when there is a loss of cervical, it is said that for OPLL, when more than 20% of the cervical canal is occluded, we should decompress it anteriorly. And we decompress it anteriorly and more than 2 levels, the spine is unstable. So it needs fixation from posterior side.
So this is the OPLs which you have done anteriorly and then turned them back.
We have done it anteriorly as well as posteriorly.
You can speak. I think everyone is loud.
With your permission, can I answer that question?
Yeah.
Yeah. Because I was the surgeon who was attending. In these cases, in OPLLs, what we did was that we analyzed the alignment of the cervical spine. The cervical spines in which the kyphosis was not more than around 10 to 11 degrees, we decided to go posteriorly. Even in that fact, considering the anterior mass of the OPLL, we decompressed posteriorly, did a laminectomy, and the decision to put a pedicular screw was always at the apical levels, at either ends. The decision to put a cervical screw at the level of the OPLL mass was depending on the size of the OPLL. But in that cases, we have gone ahead and did a lateral mass fixation at the level of OPLL, keeping the option in mind that we might have to go anteriorly if the patient doesn't recover and do an anti-excision of the OPLL. So not in not all OPLLs we have gone and did pedicles.
Okay, thank you. Next speaker is, this is an Perthes disease. The evaluation of outcome of Perthes disease at skeletal maturity. Is that right?
Yes.
Okay. So you're an exception because it's supposed to be a spine-free paper session. I hope there's no Perthes in cervical spine.
Good morning, respected Chairperson, Co-Chairperson, esteemed delegates. I am Dr. Verghese Thomas, representing KMC Manipal University. I am here to talk about our study on evaluation of outcome of Perthes disease at skeletal maturity. The outcome of Perthes disease at skeletal maturity is a spectrum which can range from a completely spherical and congruent hip joint to a completely flattened out and incongruent hip joint. It is really essential to have a reproducible outcome evaluation measure at skeletal maturity. There are various evaluation measures which have been mentioned till now, including qualitative and quantitative measures, but a single standardized and reliable system has not been accepted. The most latest one is sphericity deviation score, which is a quantitative evaluation measure, but the validity of which has not been proved till now. In this scenario, we started our study with the aims to assess the comparability of outcome evaluation measures, to assess the reproducibility of outcome evaluation measures, and to compare the outcome at skeletal maturity between operative and non-operative groups. We included the patients with age of onset less than 12 years with unilateral involvement, and among the patients who were on follow-up, we took only those patients who attained skeletal maturity. We had 75 patients in total, out of which 51 were operated by proximal femoral varus derotation osteotomy, and the rest were managed non-operatively. The qualitative radiological outcome was assessed using the Stuhlberg grading, assessing the femoral head size and the congruency of hip joint from class 1 to class 5. And also using Mohs classification, assessing the femoral head shape. The quantitative outcome was assessed using the sphericity deviation score, in which in the plane radiograph, medial and lateral reference points were marked in both AP and Launceston lateral view, and a maximum inscribed circle was drawn within the femoral head region without extending outside, and a minimum circumscribed circle was drawn at a point, the outermost point of the femoral head. The radii of two circles were noted in the AP and Launceston lateral view, and roundness error was calculated using this original formula, and also the ellipsoid deformation. And the SDS was calculated using the addition of roundness errors in both views and the ellipsoid deformation. And the clinical assessment was done with limb assessment, limb length discrepancy, range of motion, and Trendelenburg test. Tonus hip classification was used to classify the hips according to the range of motion as per grade 0 to grade 4 with increasing restriction of range of motion. Intra-class correlation coefficient and weighted kappa were used to assess the reproducibility, while gamma value and Pearson correlation coefficient were used to assess the correlation. Pearson chi-square test and Mann-Whitney U test were used as and when required. We observed that the radiological outcome evaluation measures which we studied are reproducible, and there was good correlation between Mohs and Stuhlberg, and also between Stuhlberg and SDS. The mean value of SDS was found to be higher in Stuhlberg 3 and 4 when compared to the lesser classes. And also there was good correlation between Mohs and SDS. The higher mean value of SDS we can see with poor outcome in Mohs. And the clinical outcome, the limb length discrepancy was found to be more in patients managed non-operatively and also limp. The range of motion was found to be significantly better in patients who were managed operatively. The integrity of abductor mechanism was found to be significantly better in patients who were operated. And the radiological outcome was better in the operative group as per Stuhlberg grading, Mohs classification, and SDS. So we came to the conclusion that the radiological evaluation measures which we studied are reproducible. They show strong correlation between each other, and our study validates the use of SDS, and the outcome is better in children managed operatively by femoral varus derotation osteotomy. So as a clinician, when we treat a child with active Perthes disease, our aim should be to attain a completely spherical and congruent hip joint at skeletal maturity. Thank you.
Good. Any questions?
How do you maintain all the time magnification of the X-ray? Because one time
Yes.
you take X-ray, this magnification.
Yeah.
How do you maintain?
So we are
this?
not taking the original value, sir. We are taking the ratio.
You are taking
It is the ratio, sir, not the original value.
Good. Thank you.
Thank you, sir. Thank you.
The next speaker is correlation between Cobb's angle and convexo-concave vertebral difference in scoliosis and its significance. Kishore Putezar. Is that how you say?
No, it is Kishore Puter.
Kishore?
Puter.
Puter. Sorry.
Respected teachers and friends, I would like to discuss about scoliosis, Cobb's angle, and expressing Cobb's angle as a length in scoliosis. The topic is correlation between Cobb's angle and convexo-concave vertebral difference in scoliosis and its significance. Why this study? We believe that it is easier to develop a mental picture of a length than an angle during a scoliosis correction peroperatively. Before going to the presentation proper, I have to affirm that scoliosis is a three-dimensional deformity, and addressing this problem in two-dimensionally is an incomplete effort, and we emphasize that the maximum correction of scoliosis is not the primary goal of surgical treatment, and a pilot study was not done in this case. The purpose of the presentation is threefold: to establish a linear relationship between Cobb's angle and convexo-concave vertebral difference in scoliosis, to further establish this relationship as a mathematical formulation, to propose a new method as a tool for the pre- and post-operative evaluation of scoliosis. The research questions: in patients with structural scoliosis, does a method exist to express the Cobb's angle as a length? Does such an expression theoretically improve the accuracy of surgical correction of scoliosis? I emphasize the point theoretically. 30 patients were studied, 24 females and 6 males, and all were evaluated radiologically to measure the Cobb's angle in a standard means, and another measurement was taken, that is convexo-concave vertebral difference. I will explain that. If we take a scoliosis, we can see that the convex side is longer than the concave side. So if we take the measurement AB and subtract the CD, we get a length that we can designate as Y, that is called convexo-concave vertebral difference. We statistically checked for the correlation between convexo-concave vertebral difference and the Cobb's angle. A simple geometrical construct was made to further identify any mathematical relation that may exist between them. We could find a significant linear correlation between convexo-concave vertebral difference and the Cobb's angle, as shown in the XY scatter diagram. If we take away the spine, the curve, and the first picture, what remains is a parallelogram. If we extend the AC further and BD further, it will meet at the point E. That is actually the Cobb's angle. AEB is the Cobb's angle. This simple elementary mathematics shows that the angle AEB is actually half of the double of the angle ACA dash, and we could reach at a formula y equal to 2.2 into d into sin x by 2. A perfect linear relationship exists that shows that there is a perfect linear relationship that exists between the convexo-concave vertebral difference and the Cobb's angle. Clinically, we can use either just measure the difference between the convex and concave side, or you can use the formula. In this method that we describe, only Cobb's angle and the lateral curvature that it represents are addressed. Quantifying the widely used derotation or translation techniques in correcting vertebral rotation and sagittal imbalance in scoliosis are beyond the scope of this discussion. In a paper in 2001, Lenke said that sometimes even after complete full set of pre-operative investigations, a desired correction could not be achieved. We achieve the correction by giving distraction or compression. There are various reasons for that. We believe that one reason could be the difficulty experienced by the surgeon in visualizing the proposed angle of correction peroperatively. Our method of expressing the proposed degree of correction as a length addresses this to a great extent. I will give a small example. Suppose x is the desired angle of correction in the scoliosis. Using the formula, y dash will be the corresponding length of correction attempted. If we are intervening only on the convex side, the correction required, the compression required will be A, that will be equal to y dash. Similarly, if you are distracting on the concave side, again y dash will be the amount of distraction that you will be giving. If you are correcting on the convex and concave side, you have to the combined length should be y dash. Thus, by expressing Cobb's angle as a length, the desired correction could be objectively achieved peroperatively in a predictable manner. We can also measure the maximum correction that can be achieved in a given scoliosis. Conclusion: convex or concave vertebral difference is a linear expression of the corresponding Cobb angle. By expressing the degree of correction as a length, we can more predictably and accurately perform the lateral curvature correction in scoliosis. It is possible to express desired angle of correction as a length in scoliosis. This can give surgeon greater control over the correction procedure. A clinical trial is needed to verify these statements.
Thank you. Any questions for Kishore? Well, it seems to be yeah, you have questions. You get the privilege first.
What we understand is that scoliosis is not only a lateral curvature, it is
Yes.
also a vertebral rotation.
We
So
have
in this
understood-
case, you have only taken into account the lateral curvature.
Yes.
Have you considered the vertebral rotation component?
It is difficult to quantify all these things. I am giving a small step forward to quantify one parameter. So I am not saying that is the complete thing. We have to add all these things. How to quantify the vertebral rotation, how to quantify the translation, how to quantify the angle of correction you are giving. So all this has to be quantified. So we have to move forward. So actually we are doing it as a judgment or insight, but actually it has to be quantified. So one way of quantifying the curvature is converting that into a length. So similarly you have to quantify the translation, you have to quantify the rotation. I am just giving a theoretical point.
What he's saying is that he is converting the Cobb's angle into a line, difference between the convex and concave, and he has created a formula from which you can calculate the Cobb's angle. Is that right?
Yes.
Yeah. But obviously you must know this is not it's not principles of scoliosis. He's just doing a linear measurement. The principles of scoliosis is to get balance, to get the distal end of your construct in horizontal line so that your distal disc is parallel. You have to get your shoulder correct, and it doesn't matter how much correction you get. Secondly, in the methods that he's described, which is probably a more of a assessment tool post-operatively, because per-operatively you just cannot do how much distraction, how much compression, you can't measure those, yeah, and it's a judgment by eye. So we do compression distraction on a judgment, and then we see per-operatively X-rays, and then
We
do
can
it.
use a scale also.
Yeah, but it's as it is scoliosis take 4-5 hours in my hands, and if I start using a scale to exactly quantify how much distraction compression, it's going to be a very difficult issue. But I think it's a good tool to later on post-operative X-rays measurements and things. So it's good. Okay, thank you. Safety and efficacy of posterior hemivertebrectomy and short segment instrumentation in congenital scoliosis. Amitabh Biswas. We don't have the speaker? Are you there? डिस्कशन के टाइम में ये प्रेजेंटेशन ऑन कर देना जब डिस्कशन हो रहा है ना, so it will save us time. And I will request the last 3 speakers to come and sit in the front row. The last 3 speakers. Yeah.
A very good morning to respected chairperson and all distinguished orthopedic surgeons on floor today. This is Dr. Amitabh Biswas from Park Clinic. I am going to talk on safety and efficacy of posterior hemivertebrectomy and short segment instrumentation in congenital scoliosis. Introduction, the congenital defects usually have serious consequences in the spinal growth. Without any treatment, 85% of the patients have curves greater than 41 degree in congenital scoli. The non-operative treatment is seldom successful, as 75% of these curves are progressive and only 5 to 10% can be treated with bracing. Introduction, various surgical treatment modalities have been described, like in situ posterior, in situ anterior plus posterior spinal fusion, convex hemiepiphysiodesis, hemivertebral excision, and growth fusion sparing procedures like growing rod, Webster, and Schiller procedures. Hemivertebral excision has been known to be a safe and effective procedure for congenital scoliosis and gives a better result when done early. Study design, it's a retrospective analysis of the outcome of 15 patients with congenital kyphoscoliosis who underwent posterior resection and short segment pedicle screw fixation in our center. Materials and methods, 15 patients underwent a posterior resection and short segment fixation was studied. Detailed clinical radiological assessment was done, and all patients were evaluated using scaogram, CT, and MRI of the cervical spine. All patients were screened for associated congenital anomalies. Methods, preoperative sagittal and coronal cob angle was measured. Observation, the mean age was 10 years. The lowest age was that we operated was 2 years 4 months to 24 years 10 months. The male to female ratio was 1:1.5. Winter's classification was used, in which we had type 1, 2, 3, and 4. Type 1 is the failure of formation, type 2 is failure of segmentation, type 3 is unilateral bar and contralateral hemi, and type 4 is mixed or unclassified anomalies. Now, observations, 3 out of these 9 had 2 segmented hemivertebrae at 2 different levels, non-consecutive, and 1 patient had 3 hemivertebrae, 2 segmented and 1 semi-segmented, and thereby making 14 hemivertebrae in the total 9 patients in type 1. Anatomical distribution of the anomalies, maximum number of patients had dorsolumbar hemivertebrae, 35%. Associated anomalies were present in 6 cases, that is 40%, in which we had 2 patients with leg and foot weakness, 1 with rectovaginal fistula and tethered cord, 1 had rectovestibular fistula, 1 had ileal atresia, and 1 had tetralogy of Fallot's. All these anomalies were previously diagnosed and were adequately managed. Surgical technique, all the patients were done under intraoperative neural monitoring. Pedicle screw and rod construct was used for fixation in all the cases. First pedicle screw was inserted in the intended levels. Transpedicular decancellation of the anomalous vertebrae were done, followed by complete excision over a temporary rod on the other side with controlled compression on the convexity and to achieve the coronal correction. Local bone graft was used for fusion, and patients were mobilized from the 3rd day. Brace was used for 6 weeks. Results, the mean number of hemivertebrae that was removed was 1.59. The mean follow-up was for 25 months. The mean duration of surgery was 324 minutes, and mean blood loss was 686 ml. Results, coronal correction, the mean pre-op coronal COP of 53.2 changed to mean immediate post-op coronal COP of 27.2 to a mean final follow-up coronal COP of 29.5 with a mean correction of 2.3. In the sagittal plane, the mean pre-op coronal sagittal COP was 38.1 with the immediate post-op sagittal COP of 17.3 and final COP of 18.8 at final follow-up with a mean correction of 1.5 degree. So this is to summarize, the dorsolumbar hemivertebrae had got the maximum correction in the sagittal and coronal planes, and we got the maximum sagittal correction in patients where we excised 3 hemivertebrae, and maximum coronal correction in patients where we excised 2 hemivertebrae. We had 1 patient with intraoperative motor evoked potential decrease, but that was transient and it recovered within a few weeks. So these are some few examples. 2 year 4 months male with segmented hemi at D10 associated ileal atresia, follow-up of 16 months. See the coronal COP 42 degree changing to 23 degree post-op, and 40 degree sagittal changing to 26 degree, and these are the final follow-up, immediate post-op x-rays, and these are the final follow-up comparing with the preoperative sagittal and coronal profile of the same patients. This is another patient, 4 years 6 months female, 2 segmented hemis D7 D9, and followed up for 1.5 years. These are the 2 hemis that were excised. This is comparing the pre-op and immediate post-op coronal profile. This is another patient, 4 year 3 months female, hemis at D4, D5, D6, follow-up for 35 months. This was one of the highest follow-up, longest follow-up, sorry. This is the coronal and sagittal profile at the final follow-up comparing with the preoperative. This is the clinical profile. discussion, Marx found out that maximum correction was achieved when the patient was operated less than 5 years, but in our series we got the maximum correction in patients more than 5 years, both sagittal and coronally. This was because most of the patients in less than 5 years were dorsal hemivertebrae, and we saw that maximum correction was in dorsal lumbar hemivertebrae. So 99% accuracy of pedicle screw placement in juvenile and children were reported in the literature. We also did not have any implant related complications. In our series, maximum correction of immediate postoperatively in both sagittal and coronal plane was achieved in the thoracolumbar hemivertebrae, followed by lumbar hemivertebrae, followed by thoracic ones, and this was maintained at the last follow-up also. Conclusion: posterior hemivertebrectomy and fixation fusion is a relatively less invasive and effective technique, and with the presence of intraoperative neural monitoring, it is possible to do even 2 or 3 level hemivertebrectomies with minimal risk of neurological injury. Maximum correction is achieved in the thoracolumbar vertebral anomalies. Decreased operating time, blood loss, comparable correction rates, and prevention of morbidity of anterior approach definitely makes it a rewarding procedure in the management of congenital kyphoscoliosis. Thank you.
Thank you, Dr. Biswas. Any questions for him? No questions. Okay, thank you.
Thank you, sir.
Next speaker is correlation between nitric oxide concentration of CSF and MRI cord edema in severity and prognosis of spinal cord injury. Mr. Shakti Dora. Mr. Shakti Dora? We don't have Mr. Shakti Dora here?
No, sir.
No. Okay. So the next speaker is, this is the last speaker, is it? Traumatic unstable thoracolumbar burst fracture, anterolateral or posterior approach, a comparative study of 20 cases each. Shardul Soman. Yes. Can you set the timer?
Yes.
Yeah. Only the last speaker, Biswas, exceeded his time. Otherwise, all speakers kept to the time. We're big.
Okay. Good morning. I am Dr. Shardul Soman. My topic is traumatic to unstable thoracolumbar burst fracture, whether to use an anterior lateral or a posterior approach, a comparative analysis. I declare I have no conflict of interest. Now the burst fractures as by the 3-column Dennis theory are the fractures with the compression of the anterior column, the fracture of the middle, and the retropulse fragment of the in the spinal canal. The mechanism mostly is the vertical compression of the flex spine. Of course, there can be some rotational shear in some cases. The incidence is 15 to 20%. Now the goals of any surgical management of unstable fracture are the restoring the stability and alignment, decompressing the spinal canal, and facilitating early mobilization. For operative intervention, we use the thoracolumbar classification severity scale, which classifies injury morphology, the integrity of the PLC, and the neurological status. The other measurements used by, of course, the COPS being the more reliable, and all preoperatively we analyze the MRI was done to analyze the posterior complex integrity. We included all the unstable burst fractures. The score was more than 3, suggesting operative intervention is needed. Young patients were only included, and a single vertebral fracture was included. We excluded all the pathological fractures and patients having previous spine surgery. Criteria for assessment was the Asia impairment score, was neurological assessment, and the spinal cord independence measure for the functional assessment at the final follow-up with a minimum of 6 months. The radiological assessment was using the COPS angle, the monosegmental COPS, and the preoperative MRI. This is now there is a big dilemma regarding the burst fractures, whether to operate anteriorly or to do a posterior surgery. We compared our study with the multicentric study by the German Association of Trauma and the Bashir study. These are some of the literature we use for analysis. We found that the anterior having been more morbid study, being the more morbid approach, having more hospital stay, blood loss, and of course duration of surgery. In all our patients, as compared to literature, had at least an increment of 1 scale in the Asia score. Another finding was that the use of brace, we use the brace for a minimal period of time, especially the posterior surgery. The literature suggests using it for a longer time in cases especially involving the posterior and the short segment transpedicular fixation. This is some of the cases using the posterior approach. The L1 burst fracture having initial kyphotic deformity of 31 corrected to 5. Another using an L1 burst fracture with an anterolateral approach. You can see the damage to the posterior ligament complex. Finally, as literature, we also found that the anterior was the more morbid and but however it has a more predictable decompression. In case of posterior, the damage was more to the paraspinal muscles and the persistent backache was more with the posterior surgery. Now, of course, the limitations of our study were lesser number of patients were involved. It was not a RCT, and we require a more long-term data for analysis. Conclusion and take-home message: it is unstable fracture involve a multidisciplinary approach with a team effort. Both the anterior and the posterior approaches have their advantages and disadvantages. Neurological recovery, however, is not correlated with any of the approach. The post-operative immobilization, this was one of our main findings, that post-operative immobilization required is not more than 1 to 1.5 months in case of even the short pedicle fixation, though the literature suggests that with short segments we must use it for a longer period of time. Of course, another was that for a persistent backache, if conservative treatment fails, we should advise timely implant removal in case of posterior surgery. Finally, we came to the conclusion that the approach used is mainly surgeon dependent and depends mostly on the patient's age and condition. And of course, in such fracture patterns, we would advise to do posterior surgery. Thank you.
Thank you very much. Any questions?
You would like to do an implant removal. You would like to do an implant removal.
Yes, sir.
In our practice, we don't day-to-day advise unless until we do just a posterior ligamentous or if there is any problem. Means when there is in the crowd, this message should not go that we should do implant removal for all the cases. You said that it's a good way of doing it.
Right. This is one of the way out in cases of patients who have failed conservative treatment. This should not be a routine procedure.
But no, you said timely implant removal.
Yes, in case of if the
is a good method of treatment for treatment of back pain.
Backache, yes. In 4 of our posterior patients, we found that after implant removal, the backache was reduced to almost 30 to 40% of the backache was reduced with the implant removal.
That's
so
what this inference on the depending on the 4 cases might not be right. I think Dr. Shankaracharya
I think this is just an empirical statement you have made.
Yes.
How you can't, this is purely by chance, or this is your observation or your thought process.
No,
so I don't think we will go into discussion on this. I think implant, once let me finish. Yeah, so implant removal is not, as he said, not really done in most of our cases. However, I am aware of recent literature which says that in thoracic lumbar fractures where only the superior end plate is fractured and the disc is maintained, then you just stabilize it for 9 to 10 months and then you can take out an implant so that there is no adjacent segment degeneration or stiffness in the back. So that is only for a very restricted case scenario, not for all cases scenario. Most of these case scenarios we treat them conservatively. And in our situation in India, we would treat a thoracic lumbar fracture when there is partial neurological deficit or instability or for alignment or for fusion. So the standard teaching today also is the same, that you would fix a thoracic lumbar fracture and fuse it. However, there is a very small select group of patients whom you can do a 9-month or 10-month or 12-month fixation and take it. But there is no conclusive evidence that it is beneficial. Let me finish. It's beneficial or it reduces back pain. So from 4 patients, you cannot make an inference. Yes, you want to say something? Yeah.
This is regarding some other thing. You said that the role of brace, especially in a posterior approach, is for 1.5 months or 2 months?
Yes, our mean wage was 1.4 months.
Right. Now, how do you conclude that after 1.5 months you don't require a brace? Because are you expecting fusion in 1.5 months, or
no.
what is the role of a brace? Is it just for soft tissue sort of, just to give a sort of comfortable feeling to the patient, or radiological, till you continue a brace till radiological union?
No.
So 1.5 months may what happens that you remove the brace?
Yes, sir. We remove the brace in 1.5 months. Now the main reason for highlighting this was we found that in our previous before our study started, most of patients, they continue using the braces for almost 3-4 years. So for just soft tissue healing and not for fusion. So we tried to reduce this, and this still requires more of a longer study and more number of patients to prove this. But the literature is supporting a longer, at least 5 to 6 months of usage of brace. And it mostly is for soft tissue support and for healing, not for fusion purpose.
I think we can't substantiate that. It's basically for surgeon's comfort. When the surgeon feels comfortable, he can get the patient to remove the brace. Or if the patient removes the brace whenever he wants to remove the brace. So at the moment, it's like that. Okay, I think with that, any questions? Or I wind up the session. Thank you very much.
Can I have one question, please?
Who is that? I can't see him. Yeah.
Right in front.
Yes, sure.
Yeah, I'm from Tamil Nadu. So you said that there was one grade improvement in posterior fixation. Your tabular column was showing that. But there was no mention of timing of surgery. So whether you decompress anteriorly or posteriorly, decompression is a decompression.
Right, we had posterior done at 3 days at mean, and anterior 6 days.
No, what is the relation between timing of surgery and the improvement?
No, there was no.
They haven't studied that.
Yeah, that is one thing. And secondly, in another tabular column, it was shown that in posterior instrumentation, you expect fusion. I think in case of fractures, you expect the fracture to heal and you don't aim on fusion. Is there any difference of opinion in that?
I guess that's what I have mentioned, that with the posterior...
Fusion difficult to achieve. It is not difficult. The fusion, it is the fracture union.
No, even there is a method to do laminectomy and plus bone grafting through the posterior approach as well.
Anyway, let me answer that question. Basically, it's posterolateral grafting, and you can do fusion from one side and you can decompress from other side. Thoracolumbar fractures, there is not a huge importance in decompression. So it's basically alignment and fixation and stabilization and fusion from one side, or posterolateral grafting. There is no conclusive evidence that anterior is better than posterior. And also in this study, you cannot make an inference on all those things. But it's a prospective study, isn't it?
Yes, it is.
It's a good prospective study comparing anterior and posterior, and they have 20 cases, which is good enough. So you must give him credit for that. Good, thank you.
Thank you
very much. I think that was quite an interesting session, and we had one Perthes disease in the session, which was also good. And thank you very much for a change. Thank you.
So the plan is very short. Is it useful to use X-fix? Types of spinal fixation and best way to use spinal external fixation. So some surgeons don't use external fixation. Some people really deny it. Some use it as temporary traction of fixation stage in deformities and back pain surgery. Some try to make it a basic surgery and failed. But X-fix can be an excellent in some fields. So using external fixation in low back pain problems, really some people try to do this, but the results are, as you see here, that in selecting suitable candidates for segmental spinal fusion in the heterogeneous group of patients, external spine fixation doesn't appear to be a value because it's quite dangerous and a really expensive procedure. For the other side, the external fixation can be an excellent tool in research because you can use frames in compression, distraction, use it with different implants, so it's quite easy to do this. For example, this is our very little device for fixation, for external fixation of rats' tails. Besides, you can use it as a handy tool for investigation of movements of spine. So let's speak about types. There are two types really. It's transpedicular rail fixator and Haller systems. So the system for external transpedicular fixation is very simple, and you can make different frames from it. As usually we use C-arm, or you can use X-ray or O-arm to control the position, because all procedures are percutaneous. Then you can apply every structure you want, any frame you want, and it depends on the pathology. So you see like it looks like on the scoliosis patient. HALA is usually we use 4 screw system for corona, and there is different types. HALA pelvic system, which is quite popular and easy to make from Elizarov details. HALA cast system. HALA pneumatic system, it's our investigation very simple. You can use a air balloon and details from Elizarov frame and ordinary HALA corona to make this system, to make lordosis more deep. Not to traction, but to make lordosis. To work in sagittal plane, which is really useful. Besides HALA detorsion system, which can be used in pediatric surgery, especially in Atlanta occipital fixation. So the main point for using external fixation, of course, deformities. So you can use it with very huge deformities or highly risky deformities, for especially in scoliosis, in kyphosis and rigid kyphosis, in complicated spondylolisthesis, when you can go step by step. And with HALA pelvic fixation, again, it is only safe both in spine surgery. You can use it in a very, very complex situations. When you can do nothing, for example, this guy, he really couldn't breathe because of his neck deformity. So it was an emergency procedure for us to put on this HALA pelvic system and to get him breathe. And only after this, we went to internal fixation, making this two-steps approach. And it's excellent in septic conditions, when you really can't do anything with septic situation and you need to get out all your hardware from the spine. Like in this situation, so here is anterior fusion, so we can use in this septic condition external transpedicular frame to fix all the problems. Another example, it's a 2-year boy with a very bad septic condition, lasts for 1 year. So nobody can close this wound, this bed sore.